Hello, sorry for inconvenience. No, some problem is
Ma'am,
there.
can you hear us?
मैडम ने
Hello, ma'am.
शायद अपना ऑडियो ऑफ कर रखा होगा शायद.
Bolu?
The audio, can you hear me now?
Yes,
Now
yes,
we
ma'am.
can hear.
Yes,
We can
ma'am.
Yes.
Okay.
Yeah.
The whole picture is very little. I can't seem to make it big, but that's okay. It doesn't matter.
I know, yeah, ma'am. It will become big just after 5 minutes. It will become bigger.
Acha,
We are
theek
just.
hai. I was thinking that I had done something wrong.
No, ma'am.
No.
Theek
No.
hai.
Okay. Right. Okay. Good evening, doctors. I'm Dipin Verma, the Director Operations and Marketing for Innovcare Life Sciences, and I heartily welcome you all to our yet another edition of the Pundits at Dr. Ritu show. Yeah, in fact, I correct myself. This is not the yet another. This is, in fact, the 25th edition of the Pundits at Dr. Ritu show. So, congratulations, Dr. Ritu. And, it's been a wonderful journey that, that we have come to, when we started during the lockdown period, where with a great difficulty, we organized this show, and you taken a lot of pains and have really successfully done 25 shows. Now today is the 25th show, the Silver Jubilee, and I really congratulate you, ma'am. I think it's been a wonderful, and we have been very happy to be associated with you all along. And in this journey, you have brought in such an eminent speakers from all over the country, all over the globe. And today also is not an exception that today Dr. Asha Rijhsinghani is joining us from US straight away. So we are very thrilled and very excited to watch this show every Saturday and Sunday. And so will not be a different thing. It will be although more exciting today. So, for the sake of the audience, of course, you don't need any introduction, but I have to introduce to you formally to a lot of our colleagues who joins us in between. And as we call it this as the Pundits at Dr. Ritu show. And today's show is on a webinar series on recent advances in COVID-19. Dr. Ritu Santwani is associated. She's a leading gynec and IVF specialist practicing in Pune, and she's having 20 years of experience in the field of obs and gynec. She's a director at Pune TestTube Baby Center and having a expertise in the field of IUI, ICSI, IVF assisted hatching, embryo donation, surrogate motherhood, male infertility, semen banking, embryo freezing, sexual and psychological problems, and try to give moral and emotional support to the infertility patients. So what not? I mean, so she has a one-stop solution. In fact, in the IVF, I believe. Okay,
Thank
good.
you,
And
Dipinji.
so now, yeah, very nice of you. Very, very fortunate to have you to our anchor. And now I want to introduce to you Asha Rijhsinghani. She's based in US. Yeah. Can you just come to the next slide, Weber? Yeah. So Dr. Asha Rijhsinghani, she's the MD, FACOG, and is a professor of maternal and fetal medicine, Department of Obstetrics and Gynecology in Albany Medical College in Albany, NY, USA. She's attached to the University of Iowa City in US, and she's the International Ambassador, Society of Maternal and Medicine of US. So and also I came to know just some time back that you are in the committee of developing the vaccine for COVID. So for which the entire globe, entire world is waiting for it. Okay, so you are in fact the most sought after person. Okay, who can give answers to this mysterious, the viral, which has actually stopped everybody's economy, the world because of this. And I think probably you are the key person who has the answer to it. Okay. So anyway, more time, and we are just for the audience, information. We are also live on Facebook and YouTube. And Innovcare Life Sciences is a company which is based in Mumbai and has in a lot of exciting products on gynecs and infertility range, and we are very happy to share. But before we start the program, I just want to bring in our Chief Operating Officer, Mr. Amit Mala, who has already joined us today on the 25th show. And, I want to invite him today as a guest of honor. Okay, and he will be just giving his thoughts on the program and also on how do we go about in future, and also will be interacting with you. So I invite Mr. Amitji, and he's in fact the Chief Operating Officer of InnovCare Life Sciences, giving us a new direction to the company to take it to the next level. Over to you, Amitji.
Thanks a lot, Dipinji. Thank you very much. And good evening to all, and good morning to Dr. Asha. It's a great honor for me to be talking with you all on this very exciting occasion, and I'm delighted to have the opportunity to be part of such a talented gathering of doctors across the globe, and especially Dr. Ritu Santwani today and Dr. Asha. I remember very well InnoCare, with help of Dr. Ritu Santwani, started Pundit show around 4 months back and during this pandemic, and since then it has become bigger and better with each passing day and each passing show. It's very important for us to understand what makes Pundit show very unique and special. As we know, it's a knowledge sharing platform for experts as well as young doctors. The perfect mixing and mingling done by Dr. Ritu Santwani is very special when it comes to strike balance between very basic questions and advanced ones. Not only doctors from India, but from across the globe are getting benefited out of this show. As we know, it has been covering all aspects, be it gynecology, ops, sexual wellness, women's health, medical legal aspects, and others. We truly believe at InnoCare Life Science and are always on the forefront when it comes to support medical education across specialties. Apart from conducting Pundit show with Dr. Ritu Santwani, we have been conducting various other programs and workshops to help medical fraternity, and the recent ones are such as masterclass series in gynae and ortho segments, expert talk for physicians, consulting physicians, and so on. The list is long. You can get all the details at InnoCare page. I would like to request you all, kindly spread the word with your colleagues and friends so they can also get benefited out of this. Again, on this very special occasion, I would like to congratulate Dr. Ritu Santwani on this 25th Pundit show, which has already become noted as one of the most successful show, and it has reached this stage only by listening and responding to all doctors across the globe. Thanks a lot once again, Dr. Ritu.
Thank you, Amitji, and thank you, Deepak.
Thank you. It's all yours, ma'am. You can take this show forward.
Yeah.
Over to you, ma'am.
Yeah. Thank you so much. A very, very warm welcome to my very own dear Asha ma'am. So before we start, friends, so congratulations to all of you for being with us in this journey of the today we are celebrating the 25th episode of the Pundit show. So I think it is not possible without your cooperation. आजकल ऐसा होने लगा है कि लोग मुझे खुद बोलते हैं कि आपके अगले शो के गेस्ट कौन होंगे. So this is not possible only by me, because all the pundits what am I inviting, they are sharing such an enhancement of the knowledge. And besides, I will switch on to the question answer. I want to give a big applause to the InnovaCare Life Sciences. Without their cooperation, it is not possible. My side, big thanks to Lalit ji, Dipin ji, Amit ji, and our superheroes Sankalp, Harish, and Vaibhav, and Anand, जिनके बिना ये प्रोग्राम पॉसिबल नहीं था, जो सामने भी रहते हैं और beyond the stage और beyond the camera also they are working. So friends, so many persons, so congratulations are giving. Thank you so much. So all of you know, today is the 25th episode, Silver Jubilee show. So I have invited once again here the legend, the Asha ma'am. My own Asha ma'am is with us. So thank you so much, Asha ma'am, for accepting the invitation. Ma'am, again I am going to invite you with this red flowers for you.
Thank you. I can smell them.
So nice of you, ma'am. Thank you so much, ma'am. So friends, as all of you know, कि अभी COVID-19, so this is the COVID-19 pandemic still going on. तो अभी 2020 का जो एम है मैम, हम लोग हिंदी में यहाँ पे ऐसे बोल रहे हैं 2020 का एक ही लक्ष्य का आने तक टिके रहना. So, so we are going to have detailed discussions. What are the advancement? What is the vaccine progression with our own Asha ma'am? Asha ma'am is our very own Asha ma'am. Ma'am, चाहे US में हो या कहाँ पे हो, with my तो single phone call, ma'am always accept my invitation. So, ma'am, I'm again honored to have you here. This is in the history of the Pundit show that ma'am is the repeated guest on the 25th episode. Thank you, ma'am. So, ma'am, I now I'm starting the show. Yeah. So, ma'am, I want to know, ma'am, what are the reasons for this COVID-19 regarding this airborne transmission?
Yeah, I'll answer that just very quickly. So the vaccine program that is being tested, New York State is a big one, so it's not me personally involved in it. My institution is involved in it. Governor Cuomo, he lives, I'm sure many of you have heard of him, in our city. Ours is a small city. It's the capital of New York City, so my hospital, Albany Medical Center, is involved in that. And we have some phenomenal ICU doctors that are very actively involved. So in that sense, we are involved, but I'm not making them or doing anything currently. In terms of my ICU colleagues are the main people that are involved in it. So I just want to clarify. So airborne infection, you know that there was a big tip about this. The the researchers started saying that it's aerosolized, and WHO took a little bit of time to agree to it. And the reason was because the infection is spreading so fast and so many people that cannot even remember where they got exposed because they've been using all the possible precautions while going to stores, just ordinary people while going to stores or going to work. They've been putting their masks and keeping the distance. In spite of that, they're getting infected. So the thinking is that it's aerosolized rather than just droplets. When you say droplets, the particles are more than 5 micromillimeters, and in aerosolized, they are smaller particles, less than 5 micromillimeters, which will enter through the mask. The mask will not stop it. And that's why there was this push, and WHO finally had to agree that it was probably aerosolized also, not just droplets. So we need to do more than just masking. We need to do masking, distancing, plus shields. And the problem is, majority of the people who are getting sick from their own family members and their own close friends and colleagues, and they let down their guards, and that's where they're getting infected. They're not getting infected necessarily always through patients. So there's a lot of cross infection going on, and it's a lot of the aerosolization, not just droplets. So any dealings with patients in the hospital, please try to cover your eyes and your face. So either goggles and mask, or mask and shields.
Yeah. Thank you. Thank you so much, ma'am. Ma'am, these days we are reading a lot about this saliva testing. So how much it is authenticated? Please enlighten us about that also.
So, the saliva test is a very, very easy test, and it just got the FDA approval for use under emergency approval. It's called EUA or something. But the reason is that the RT-PCR, which is the most reliable test, antigen test is not very reliable. The sensitivity is much lower. So the RT-PCR is the best test, but it takes several days sometimes. It can take just from, less than a day to several days. And so it's not really ideal for mass sort of screening. Plus, by the time the results come back, most people have exposed others to the infection, and it's a very expensive test. I think somewhere I read that some patient had to pay $450 for the test. So very expensive. So Yale people came up with this direct saliva test, which is almost like a litmus paper. You can get the results very, very quickly within definitely less than an hour. And it's very easy in the sense, For the RT-PCR, they use special nasopharyngeal swabs, which are really long and special swabs, and then they put them in these special tubes where apparently the RNA is going to be preserved, and then the transport and so on. And then the person who is doing it is a healthcare worker who's taking these samples. But in a saliva direct test, the patient just simply, these are only for asymptomatic. If somebody is sick, really having symptoms, you should do the RT-PCR. But the saliva direct test, you simply spit into a bag and the RNA stays there for days. It doesn't spoil. You don't need any special tube or any special swab or anything special. So all of these cost under $5. In some labs, they say it'll be only $1 to $2. And by the time the patient gets charged, it's $10. But the turnaround is so quick that the Yale people are going to be doing it on their players. They, each university here has football and basketball players and so on. So that's where the infection is really spreading amongst these sports teams. So they will be doing it daily and very cheap, and they have described how to do it. It is also an RT-PCR test, but it's done much fast, and so they want the whole world to do it. They are not going to trademark it so that everybody will be able to do it and do it very cheaply, and they're hoping that they can do 4 million tests in a day or some such huge numbers rather than the numbers that are currently being offered.
Yeah, ma'am. Thank you so much, ma'am, for the clarification. Ma'am, we want to know what's the current status regarding the treatment for the use of. First, I want to know regarding the use of this HCQ, hydroxychloroquine.
So, the problem with hydroxychloroquine is there have been many studies that have looked at it, and there was in UK there is there is a team doing studies. It's called the recovery trial. So if you Google recovery in uppercase, all capital words, recovery trial, you will see it's an ongoing study. They're really doing a phenomenal job there. And these are randomized trials, and they actually randomized about I think over 4,000 patients, of which 1,500 got the hydroxychloroquine, and the rest, about 2,500, did not get it. And then they looked, this was done prospectively, and then they looked and it didn't make any difference. And in fact, in some cases, there was an indication that hydroxychloroquine may have been associated with slightly higher morbidity, slightly higher mortality. So it was done for sicker people, people with moderate to severe disease. And so the mortality actually with hydroxychloroquine was like close to 27%, and without that it was 25%. Also, in terms of ventilation, more people required ventilation, 42% with hydroxychloroquine versus 40% without hydroxychloroquine. So the thinking is that same with the oxygen requirement also. More people required oxygen, those with moderately severe disease that were admitted. Now, not everybody gets admitted in places like UK and US. I think in India, they admit anybody who is positive, but here you get admitted only for moderate to severe. So the studies have been done in this population. There is also some indication that giving it to the milder cases also will make it bad for them, so it should not. But there really is not a good study on prophylaxis. So all bets are off in terms of prophylaxis. I know that IMA recommends doing it, but it's really not based on any well done study. And one more thing I just want to let you know, the hydroxychloroquine and that 1,500 odd patients that they used in the UK recovery trial, none of them had cardiac issues. So
Okay.
it didn't cause heart problems. That's the worry that has been there with hydroxychloroquine, that it will cause heart problems, but it did not. But those people died because for some reason, they died. They were very sick. And so is a 27% death or 26.8% death any worse than a 25.3% death? Probably not in an institution, but worldwide it will then start to add up. So it's, no, we don't use it in the US.
Okay. Ma'am, so there are so many papers are coming still for this, the use of the HCQ for the prophylaxis. What's your opinion? Still, there is a lot of dilemma in the person's mind whether to take, whether not to take. Mm.
Yeah, I don't know. There is no study to support it.
Yeah.
And there are, people who have taken it. I know many people in India that have taken it. Many people have messaged me in my messenger box saying that they took it for a week. They had a lot of GI, so they stopped.
Yeah.
And COVID is going to go on for a couple of years. So to take it for a couple of years, that is for the person to decide. I mean, I know it. Also, it's going down over here. COVID is much, much less in New York than it used to be. In India, today, India beat the whole world. They had over 73,000 new cases. So it's speeding up to being number one in the world for the number of COVID cases. So I don't know. I know that I wouldn't take it, but if somebody has a good heart and you're taking it, I don't think it's such a big. So you should do what you feel comfortable with. Will I give a prescription to somebody? No, I wouldn't.
Okay, ma'am. Thank you so much, ma'am. Ma'am, though we are discussing this very frequently in the COVID-19 group of yours, but I purposefully asked the question here because so many young gynecologists also join here. Ma'am, as you said, but the Pune is the worst situation. Pune has now become a corona capital of India. Such a bad situation in Pune. So, ma'am, now I'm coming to the next question. Ma'am, as you have enlightened us about the HCQ, ma'am, please enlighten us about the role of the dexamethasone.
So dexamethasone was also a part of the recovery trial.
Yeah.
And the good thing is it was, the dexamethasone they gave, so it's not available everywhere, but they use the dexamethasone. And when they use the dexamethasone, it was only for the sicker people, the moderate to severely sick people, not for the mild people. And when they used it for the sicker people, they saw that the death rate had decreased by 30%. When it was used for the milder people, it did more harm. So the recovery trial, it has many, many papers, many studies they're doing, but they strongly recommended against it for the milder cases, because milder cases will do badly, but the severe cases will do better. And when you don't have dexamethasone, you could use the other steroids. But if you can get dexamethasone, then that is sort of the most preferred one.
Thank you so much, ma'am. Ma'am, regarding the use of interferon.
Oh, interferon. There is a recent, I'm hoping it's going to work. There is a recent study on about 101 patients. It's interferon B1A.
Yeah.
So they are using it, and they did a randomized trial, but only 101 patients. And so they are saying that they need to do a bigger trial, but the company, and there are some very well-known doctors associated with this trial, and they saw that it reduced the death rate in ventilated patient. Actually, in their study of 101 patients, those that got the interferon beta 1A, there were no deaths. But it's a small study, and out of 100 patients, 20 will be very, very ill, and of the 20, few, not everybody will die, less than 10%. So the numbers are very small, but they are very enthusiastic about it. And the thinking is that it's, somebody is going to do a very big randomized trial, and that it's hopefully going to work. That's the hope, because of because reduction of 79% death, it's far bigger than 30% with dexamethasone. So, using a combination of these things in the severely ill people, it may be helpful. So the hope is there. Mm-hmm.
Thank you. Thank you so much, ma'am. Ma'am, now regarding for this treatment, we are using this convalescent plasma. So, what do you think? How much the studies have come, and what's the studies suggest?
So, the convalescent plasma, there are the studies are still being done. So there is no single study that has shown that it is absolutely something that's going to be helpful. So it's just like, any of your other medications. Is it going to be helpful? Is it harmful? It's probably not very harmful. And so there are over 150 studies on convalescent plasma, but none of these studies are very large or randomized. And currently in the world, there are more than 1,000 randomized trials going on, of which, a number of them are convalescent plasma, and they were trying to do a big study here in US. And so the thing is that it's given only to people who are positive. You have to have the test, obviously, that the person is positive, and it has to be taken only from specific people. You cannot take convalescent plasma from everybody who has had the infection. So you have to be very careful and screen the donors. And then, so a typical donor will be an older male or a female who has never had babies. Only because if somebody, females have children, then there's a possibility that she has HLA antibodies. And if she has HLA antibodies, her plasma can cause more problem if she donates it to the receiver. So if a younger woman or a woman who has had children who wants to give it, then her blood has to be tested for the HLA antibodies, and only if negative can it be given. But usually these people have been extremely ill. So an extremely ill male patient who has recovered completely, they are the only ones that they are the main ones that actually are donating. And then before, they were being very strict about before they were actually not in USA being very strict. I think in India they were being very strict about the antibody titers. And in India, from what I was told, they required a titer of 1 to 320. In USA, they were even using 1 to 80. But now they are saying it should be at least 1 to 160 for there to be enough antibodies in the plasma. And then even the volume of the plasma, how much volume can you get? So the person has to be well enough to be able to give, because a person who has just recovered from being so severely ill, you cannot be pulling out blood. So they have to be in resolution for at least 2 weeks before they give it, before they can donate it. And blood donors, they normally donate once a month, but here in the US they are allowing them to donate once a week, especially if they have high titers. And so it's given to people with severe disease, people with shortness of breath, or respirations that are higher than 30 breaths a minute, and people who are getting hypoxic. Before they used to use 93%, now they're saying 94% is hypoxia. And life threatening respiratory failure, septic shock, multiple organ dysfunction, multiple organ failure, those are the patients that are getting it. And the question is, how much is enough? Is 200 cc's enough? Majority of the donors will be able to give around 200. Few of them you can get 400 and 500 out of them. And so the question is, how do you give it? People are still trying to look at that. One of it probably should be adequate in most, but you can even give two transfusions of this convalescent plasma. The fear is that the plasma, when you're taking the plasma, it has many, many more things in it than antibodies. It has all kinds of lipids. It has occasionally cells in it. Even if you try to make it leukocyte poor, it may have cytokines in it. So when you're injecting it, the person is getting all kinds of stuff in it. And so because of that, there is a push to actually developing the monoclonal antibodies. I don't know if you were going to ask me about monoclonal antibodies, but people are trying to make monoclonal antibodies in the lab. And so those are pure antibodies. And so instead of taking antibodies from a recovered patient's plasma, a convalescent plasma, you would use these antibodies that are manufactured in the lab, and they do as good. And they are pure antibodies. So patients will be able to tolerate those far better. I just saw, I saw a talk yesterday by 3 virologists here in USA, and it was a webinar, and they said one of them is concerned that monoclonal antibodies will not be enough. We need polyclonal antibodies because maybe the virus, some of the spike proteins may mutate a bit, in which case the monoclonal antibodies may not work as well. So he thinks that polyclonal antibodies will be needed. But right now, there's a big push to doing the monoclonal antibodies. They're made from rats and stuff. And people make monoclonal antibodies all the time for cancer treatment. So the science is there. And, people are actively trying to manufacture it. I don't know if that answered all your questions. If you had any other questions of,
No, ma'am, now very, very important for that. All are very waiting to hear from you. What's regarding the vaccine update?
So, it looks very good. There are 8 vaccines.
Okay.
So actually there are 150 vaccines, and India is also trying to make some of the vaccines. And the Trump government signed, I think, $7 billion or $8 billion, I think, for 7 companies.
Okay.
And one of those companies is the Oxford. So there are 3 big companies. So the US has given money to UK, to the Oxford company called AstraZeneca. Okay. And to some of the American companies and some other companies it has given money to, this $800 billion. And so the 3 of the 150, probably 15 or so are probably decent vaccines, of which 3 of them are really racing and doing very well. So one of them is from US, the Moderna vaccine from Boston. One is, and Dr. Fauci is, part of that. One is the Oxford vaccine, the AstraZeneca, and one is a Chinese vaccine. And all 3 of them are in phase 3 trials.
Okay.
Those are the only 3 that are in phase 3 trials. So when you do vaccine trials, you have to have phase 1, just, like 40, 50 patients. And then phase 2 is probably 1,000 patients. And then phase 3 is like 30,000 patients. So phase 1, you give it to make sure nobody is going to die on it. So it is just to see the safety of it, like for major problems. The phase 2, where you have about 1,000 patients, you give the vaccine in varying doses. So 10, 30, 50, and 100. I think that's what the doses were, micrograms that were being given, to see which one will elicit a response. And then the third, and then when you see that there is response with 50, you don't need to give 100 or 200 or 250. I think in USA they had tried in the phase 1 giving 200 and 250, and I think 2 or 3 people got deathly ill on that. So they have cut down the dose. So in the 1,000 people, they got this lower dose because they elicited a response. So these vaccines are working and they're making antibodies. But you want to know, even if 1 in 1,000 gets sick, and in order to do that, you have to recruit thousands of patients. So they're recruiting about 30,000 patients in the US, and they're hoping that by end of December to beginning of January, they will have, I think, 200 million vaccines available in the US. And next year, by 2021, end of 2021, they will have over 2 billion vaccines available for people in the world. And it will be given to nursing homes where there are older people, and to the hospitals and to the clinics where these COVID patients are going. and the public will get it. The younger people, the public will get it much later. It's going to be for these people. So the hope is there. The only downside is that in order to see the safety of it, you want the population, that the 30,000 population that are being tested, you want them to be of all the races. You want it to represent the real population. So in the US, all the Caucasians, all the white people are going for the test, for the vaccine trial. The Black population, the Hispanic population, which makes up 35% of the American population, very few of them are going for it. So that is a problem, because they don't know if it's going to work in that population. They're trying to get more of the minority population to be involved in the study. So we know that it works. We know that it won't harm them. So that's one downside. The other downside is that for the people, the other downside is people are very afraid and they don't want to take the vaccine. At least 30% of the population said they won't take the vaccine because they think it's going to be bad for them. And then yet another bunch of people, such as me actually, some of us said that we are not going to take the first batch. We will wait 6 months to be sure that nobody is getting harmed by it. So probably there'll be 3 generations of vaccines. Once the vaccine comes out, it'll be working and they'll say, oh, let's make it better. Then there'll be a second generation, and yet they want it better, third generation. So they think the third generation will be out probably in June, July. So I thought, okay, I'll wait for the third generation. If everybody waits for the third generation, there won't be any first and second. So that's the downside. We all need to step up and go get our vaccines when they come available.
Thank you, ma'am, for such a nice explanation. Ma'am, there are few viewers have joined from the Facebook. Yeah, ma'am, Dr. Anita Ramesh has joined. She is asking, in patients who are in active labor, can we rely only on the antigen test? If the antigen test is negative, can we treat them as COVID negative patient?
I would say no, only because antigen test does not have a very high sensitivity. Your best test is RT-PCR. And if the saliva test comes about, which I think it will probably be available soon because FDA has approved it for the US use for Yale only. And because Yale had applied for this emergency use for their football players and university students, because in the universities here, it's been terrible. Many universities have had to shut down because there are so many clusters of infections among students. But if it becomes widely available, that would be a better test because it's supposed to be 80%. It's not 100%, but it's 80%. And the antigen test is lesser than that. It's more, a little bit more difficult to do, but I believe the sensitivity is close to 60%. And so, even if somebody is testing negative, please, the best thing is to do your RT-PCR within 5 to 7 days before the patient, do it at 38 weeks. Tell the patient to isolate after she has the RT-PCR, which is negative. Isolate for at least a week, and then she comes to you for delivery. Then you know that she's okay, because by then, hopefully, if she has the infection, she'll have symptoms. Sure, she can get infected the day before if she doesn't isolate herself and stay at home, and then she can come and infect you. So it all depends on how reliable your patient is going to be. Patients here are super reliable, most of them. Some of them are real, difficult, but majority will isolate themselves. We do the test a week before, and then we induce them. And we use the shield and the mask with all these patients. But if there's any hint that she may have an active infection, then we would use the whole PPE. Patients also wear masks, and when they're pushing, we try to have like a sheet between the patient and the doctor who is doing the delivery, because these people can scream and yell and all that, it'll aerosolize and come into your face. So we try to put a plastic sheet. But you have to, especially in India, I would be very afraid to do deliveries in India without proper precaution in 100% of the patients, especially people, the so-called upper middle class or whatever, they have servants coming in, and I'm sure you have heard, because I've heard of so many people. They're building, they are in beautiful buildings, and the third floor neighbor or the fifth floor neighbor is sick, and his father died because he got sick. And where did you get the sickness? Nobody knows, but its servants are coming into the house. And it can easily be passed on from your movie stars got sick, right? The Bachchan family, like,
Yeah.
so people are getting sick and they're spreading it amongst the family members. That is where, there's 40% it from family members or from friends, your best buddy, and you sit and have tea together, and the buddy just, isn't even symptomatic, because 40 to 50% people are asymptomatic or pre-symptomatic, and they'll give it to you, and you might be an older male or a male with some high risk factor, and lo and behold, you can get sick, and your colleague doesn't even know she or he has it, because she or he may be younger. So please be careful with every single person. Too many doctors are dying, and we are
Yeah.
trusting our colleagues. So don't trust anybody. And patients,
Yeah.
of course, keep your distance from patients.
Yeah. Thank you. Thank you so much, ma'am. Ma'am, Dr. Sushma Bakshi, madam, past president of Menopause Society. Ma'am is from
Yes.
Baroda. Ma'am is also joined. Welcome, Sushma, ma'am. Ma'am is asking, after how many days can we say that a COVID positive patient is now out of danger and can resume work? And what is the role of doxycycline?
So, doxycycline has been looked at, and there is no support for that. There have been studies done with um, hydroxychloroquine and doxycycline, or hydroxychloroquine, and not necessarily doxy. What is it called? Erythromycin and
Azithromycin. Yeah.
azithromycin. Yeah.
Yeah.
Look up the recovery, UK recovery trial. Um, these are not doing anything. They're not helping in any way. And these trials, again, they are in people with moderate to severe disease, but it hasn't done anything to help them. And so I don't know. There are lots of trials going on. Every day, so many studies are coming out. In fact, people are getting so confused about what to do, whom to follow, what to follow. Every single day there are dozens of studies that are being published, so it's a very vulnerable feeling, and you say something today and tomorrow it's completely different. For example, plasma, we said, we don't know plasma is working, and there are these huge trials going on in the US for plasma. And last week, a few days ago, the FDA plasma for treatment as an emergency treatment, though there's no data. And so everyone who is trying to do the study yesterday, that virologist, the webinar that I was listening to, the fellow said that, we cannot do the study now because FDA just gave them permission to use it without any documented. So same way with doxycycline, erythromycin, hydrochlorothiazide, so many virals. And then somebody this morning, methylene blue, apparently there's a clinic where people are putting, the doctors are using methylene blue. They're drinking a couple of drops every day or putting it in under the tongue, and they think they're protected, but there is no data to show that.
Okay.
So be careful with all these medications. Just trust your usual things, your mask, your shields, your distancing, less than 15 minutes interaction with your patients or with anybody. And that washing your hands, not touching your face, those are the main things that are going to help. None of the other it's a desire, but we still don't have any. There's no game changer, and there's no silver bullet in this. It's all very dicey.
Yeah. Thank you. Thank you so much, ma'am. Ma'am, one more question by Dr. Bakshi, madam, only. That after how many days we can say the COVID positive patient is out of danger?
Sure. Yeah. So it depends on how severe it is. So people who are mildly affected versus people who are severely affected versus those that are asymptomatic. So if somebody is tested as positive and has absolutely no symptoms whatsoever, from the day they have tested positive, 10 days, asymptomatic patients, 10 days. And if they have had no fevers, no symptoms, nothing in the prior 24 hours, they can be liberated if they're healthy. If you have asymptomatic patient, but the person is diabetic or has lupus or whatever autoimmune disease or some kind of high risk factor, then in those asymptomatic patients, wait 20 days. You don't need to repeat the RT-PCR. You had a positive RT-PCR, 10 days for a normal healthy person and 20 days for somebody with a high risk factor. If they're asymptomatic and in the prior 24 hours they haven't had a single temperature or anything, they are liberated, they can go out. They don't need to isolate themselves. In people with moderate to severe disease, it's 20 days from the day the test was positive. So 20 days in those people plus minimum 24 hours of no symptoms, then they should be considered non-infectious. And so in these ICUs, you'll see people there for a month and a half, two. We had a wonderful person, young 41-year-old Nick. I forget his name. He's a musician. He was a musician in New York. Just a brilliant guy, very young, very healthy, exercising, just fantastic. And as you know, almost half of the cases are in these young people. But he was in the hospital for, I believe, close to 3 months. He was not infectious, but the virus had gone. In 3 weeks, it had disappeared. But he had so many after effects, strokes and thrombus and necrosis of his legs and fibrosis of his lungs, and it was just terrible. So the viral symptoms can last for a few months. The virus itself, by 3 weeks, it's gone. So if you're discharged from the hospital and it's 3 weeks, 20 days, and you haven't had symptoms, you are free to go out and say hi to your family members.
Yeah. Thank you. Thank you so much, ma'am. Ma'am, our dear friend Dr. Madhu Gupta, she is joined from Kanpur. Madhu is asking the role of ivermectin.
Those are those antivirals. So all of these studies are going on, and there is the Infectious Disease Society of America. So they actually keep, because of so many papers being published every day, they are struggling to keep up with the literature for the physicians here in the US. And so I looked up their list, August 20th, it was updated. And then when they update it, they'll say, please do not hold us responsible. This can change tomorrow. But as of today, this is what holds true. So, they are saying, and not just them, but even the Oxford UK recovery trial, they're saying none of these antivirals have been proven to do anything. So they should be given only if there is a trial going on, not otherwise. So people should not be using medications haphazardly. They should do it only. And the thing is, not 100% people don't die. Maybe 5% or 10% of the older people will die. People who go on ventilators, 40% will die, but 60% will live. And so, when those sickest of the sick people on the ventilators that live, if somebody has given some antivirals and maybe azithromax or something, then they'll claim that those medicines worked. You can't claim that, because you just don't. I had breakfast and I did not get the flu. My husband did not have breakfast and he got the flu. So maybe eating breakfast prevents flu, but that's not true. It's just an association. It's not a cause and effect. So people who are giving all these drugs and they say, oh, I did this, I did that, and I saved 3 years old or whatever, it's not cause and effect. It's just an association. There's no proof that these things work. And so just using it, just be sure that if you're using it, that it's look up the side effects to be sure the patient isn't getting side effects from these medications.
Yeah. Thank you. Thank you so much, ma'am. Dr. Pam joined, Secretary of Gwalior Society. Ma'am is joined. Ma'am is asking about the relapse. I think Asha ma'am just told us about the detail. Dr. Lakshman Rana has joined, asking about the plasma therapy. That also, madam, has detailed discussion. Mr. Rajendra Herde, I think your question is also, madam has given us the detailed answer. I think some are joining late, so the same questions. You can log in and see the whole session is available on the YouTube and Facebook. Ma'am, now my other question to you, ma'am,
Just
what?
let me just, I'll just, about the plasma.
Yeah,
I think India is doing a big trial somewhere in South India. They're doing a big trial,
yeah,
but but so far the trials have not shown a definite benefit. Though in the US it was approved as an emergency treatment for the sickest of the patients. The FDA approved it. So the trials are, hopefully they'll still go on for the moderate people, but the jury is still out there, though US has started using it for the sickest of the sick people and the plasma, those that have high titers. I just want to add one thing, Ritu.
yes,
You
ma'am.
know, completely forgot. So vaccinations, the three vaccines that I had, the Moderna vaccine, the AstraZeneca, and then the Chinese vaccine, those three vaccines, they have looked at the titers after giving the vaccine. The Moderna vaccine, the US vaccine, looked at the titers, and those antibody titers after the vaccine was up to 4 times that of a convalescent plasma.
Okay.
So vaccines is really giving you a very, very, very high titer, and so it's protective. So I just wanted to mention that. I forgot to say that before. And then I also forgot to, about the vaccines, I forgot to say that, the Russian vaccine, they have not done a phase 3 trial. So
Okay.
nobody really knows, how safe it is. So at least the American people were told, please do not ever get it because there is no safety data on it. They have done a phase 1 trial, maybe phase 2, but definitely not the phase 3. So actually, Dr. Fauci went on air and he cautioned people about that. And he said we would not be, using those kinds of vaccines. So just a word
Okay.
about vaccines.
No, that's great. So, ma'am, by December, is there a possibility that we will get the vaccine if the phase 3
Yes,
trial is going on?
the vaccines are already under production. So
Yeah.
they're already making it and stockpiling.
Okay.
And that's why, this 8 billion or 7 billion, $8 billion. So
Okay.
yeah, the stockpiles are already
Okay.
on the shelf. They won't release it until
Okay.
the phase 3 trial is over. They
Yeah.
won't release it.
Okay. 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 Yeah. Thank you. Thank you so much, ma'am. Ma'am, now my one question is regarding the what are the long term effects of COVID-19? What the studies are giving us the impression that what will be the long term effects? Till now, what the studies have come?
So, the long term effects are really terrible in some people, not in everyone. It's really causing too many problems in some people. But the good thing is, most patients will do fine and recover completely. So, no need to worry for majority of the cases. But a few of them will have, even people who had the mild disease, according to the US, mild disease meaning they didn't need oxygen, they didn't need admission, because they will not admit you unless you need oxygen over here. So even people who have mild disease, they can have these long-term symptoms. So you'll need to watch for that. And the long-term symptoms are, hair loss is a big one. People are completely like losing all their hair. And some people have started to gain the hair back, but for 6 months they can keep losing it. Um, it can, lung fibrosis, so going from head to toes.
Oh,
Lung fibrosis is a major, major issue. These people's lungs just completely, there's such severe alveolar damage because lot of thrombosis. This is not pulmonary embolism coming from the legs. This is pulmonary, it's sort of miliary tiny thrombi, and they are damaging the alveoli very severely and causing fibrosis. And some people have asked about lung transplant. There have been a couple of lung transplants done in the world for COVID-19 cases, but it's very hard to do it. And these people end up with lots of, forget the lung transplant, but the few of them that have lung fibrosis, it causes lot of respiratory, long-term respiratory issues, from the tracheostomy, from the high pressure that was used in the ventilation, that itself damages the alveoli. And so something not, not a nice thing. Neurologically, there are some young people, they've been mostly in young people, the neurologic injuries, they've had large clots in the brains, not just in veins, but even in the arteries. There were about, I think, 7 patients in New York that showed up in a short period of time, and they were not even going to the doctors. They didn't think it was COVID-19, and they stayed at home because they were afraid to go to the hospital. By the time they went, they all did pretty badly, but some worse than the others. I think one of them died, and then one lady, she recovered, but some of the guys, they had, paralysis from that. And so these people go in, the neurosurgeons, they're called stat at 2 and 1 in the morning. They go into the brain, they try to pull out the clot. And one of them described the neurosurgeon says, as he was pulling out the venous clot, there was an artery next to the vein. And he actually saw the clot forming in the artery as he was pulling out the venous clot. So the coronavirus is very pro coagulation, and for some reason it's causing immense amount of coagulation everywhere in the body, in the kidneys, in the liver, in the lungs, in the brain, in the legs. That Neil, that actor, he got his leg cut off. It was so sad, and in the end he died because his kidneys shut down, then his lungs shut down. And but, and so all of these, the immune system can get damaged, liver can get damaged. And people who have lost smell, some of them have lost smell, it's been 6 months and it hasn't come back. So how people say, "Arey, hone wala hai yaar, no problem, ek baar to hona hi hai." Don't do ek baar to hona hi hai. Maybe you're young, you may recover completely, but your grandmother won't, your neighbor won't. And these people go around socializing. I mean, thank goodness that Amitabh Bachchan healed, but if he had become sick, he potentially could have had severe long-term effects. And then, so you're making the older people get really sick. And again, 40 to 50% of the very sick people are the young people, because bachna chalta hai, sab kuch chalta hai. So they get so much infection. They are the ones that are ending up with these kinds of issues, many of them.
Yeah. Thank you. Thank you so much, ma'am. I was just reading today only in our COVID-19 group. Ma'am, some doctors have raised about the question regarding the use of phenofibrate. So, ma'am, any studies in the favor of that?
No, I mean, these are again, hit or miss. There are so
Okay.
many such medications. I wouldn't know.
Huh.
Going back to the long term, I
Yeah.
also wanted you to know, which I missed saying, even the heart, it can cause acute heart injury, it can cause hypertrophy, it can cause the heart muscles, you can have necrosis of the cardiomyocytes. And so some kind of microvascular thrombosis can happen. So it damage the heart. So be careful. I forgot to mention the heart.
Okay. Thank you. Thank you so much, ma'am. Ma'am, Dr. Shabina has joined. She is asking, please enlighten us about the post-COVID symptoms. Will they disappear over the time? Madam has just discussed. One more question she is asking. What about the role of pyroxicam and phenofibrate?
I don't know about those two medications, but
Yeah.
in terms of the long-term symptoms, because I think I remember, Sabina was talking about it, and we had
Yeah.
discussed this a bit. Tachycardia, which I failed to mention. Many patients have SVTs, and the heart rates can go up into the 150s to 180s to 200, very sporadic. And they keep going back to the doctor to get, when they go to the doctor, the heart rate is normal. And then suddenly they come home and it's very severe palpitations where they can feel a lot of palpitations. And so these symptoms, they are very sporadic. There's no medication for it, and the doctors will keep trying to reassure you that there's nothing wrong with the heart. but that is something that patients have, many people have complained about it, that they have this persistent intermittent palpitations and they don't know what to do about it. But the best thing is to just keep living your life and not focusing on it if you had the infection. And some people are having these because it's causing a lot of, especially in places where there's a lot of infection, um, patients are having a lot of emotional difficulties with this disease. Um, and then some people who have had the disease also have some brain effects from it, such as delirium and psychological effects. And so, these are things that we need to be a little bit more careful about, because these are going to continue. And what is from the infection and what is just the severe psychological issues, it's hard to pinpoint, but there have been lots and lots of psychological problems and psychosomatic PTSD, especially people who have been intubated. They don't even remember what happened once you extubate them, but there's been a lot of PTSD in those people. So something, it's good to have some kind of webinar where you have positive things going on, sort of counseling each other. Like I had it, there's one big group here in US, and I think there are 8 people on it, most of them who have been infected, and they discuss and they support each other. And and I actually belong to that group, and intermittently I'll put in something. I try not to, because being a physician, if I do something and something bad happens, they sue my hospital. So I try not to, it's America. So I try not to be too free in giving my opinions to them, but they are supporting each other, and it's a very tough disease. Many of them are having PTSD, the depression, anxiety, and the palpitations make it worse, because some people truly have palpitations. So
Yeah,
it can go on for months.
yeah. Thank you. Questions are non-ending. We have exceeded more than 1 hour. I will take more questions, ma'am, with your permission.
Sure.
Yeah. Mr. Dr. Talukdar is writing the chances of relapse of COVID-19 and what are the possibilities of neurological damage?
So there have been only a couple of cases, right? I'm waiting to see about the one case in US, in Nevada, that they talked about. But the one case from Hong Kong, so reinfection is something that is so extremely rare. And so really there's no data on that yet. But the guy in Hong Kong, he is a bona fide reinfection, because he was infected on March, I think 26th or something, somewhere mid to end of March. And then he was, the virus should have gone by now. And 5 months down the road, he went for a business to Spain, and then he went to UK. And then from UK, he went back to Hong Kong. And as routine, they tested him in Hong Kong. And he said, I've had the infection. No, we are testing everyone. And so he tested positive with the RT-PCR. And so when RT-PCR is positive, it just tells you that the RNA is there. It could be dead. So it can be positive for 2, 3, 4, 5, 6 weeks, 2 months, but usually not 5 to 6 months. So anyway, he tested positive, and then Hong Kong really has done a great job, and they had his virus from before, and this new infection, and they tested the two viruses, and they were, of course, they both were coronaviruses, the SARS-CoV-2 virus, but there was a slight difference when they did the genetic test. There was a slight difference between the two viruses. That's how they knew that this was a recurrent infection. And then they looked at the antibody titers. So after the initial infection, his antibodies had gone up and then come down. And then when he was asymptomatic, but his antibodies literally jumped way up. Or that was somebody who was working up that case actually put up a beautiful graph showing how the antibodies. So I'm thinking they were his, they didn't clarify it. Anyway, so your T cells and your B cells, they have memory. And so if you get hit again by the virus, the hope is your antibodies will jump up very, very quickly, and that you will not get a bad disease time. Um, uh, this guy, one case, I think somewhere in India, they're saying, in India, I mean, I'm hearing of reinfections everywhere, but I'm wondering if they're reinfections because you really need the genetic test. These, if they are positive for RT-PCR, it may just be the dead RNA that can hang around for a couple months. So reinfection hopefully won't be that bad. It's simple. It's similar to like giving the monoclonal antibodies. So if you are exposed and your RT-PCR is positive and you're asymptomatic, or pre-symptomatic, maybe giving you a shot of the monoclonal antibodies will prevent you from getting moderate to severely ill. Maybe, that's the hope, and they're going to be doing the trials. Similarly, instead of getting a monoclonal antibody from a rat, people who have had infections before, their own antibodies will jump up and protect them from getting a bad reinfection. So that is the current thinking.
Thank you so much, ma'am. Thank you for enlightening us. I think with this we will wind up because I've already taken more than an hour of you, ma'am. Thank you so much for taking out your precious time in spite of being a Sunday. Thank you for
No, it's
enlightening
a
us.
pleasure. I'm so glad to see Dr. Bakshi, Dr. Gupta,
Yeah.
Sabina Inayat, so many. I mean,
मैम हम
they
सब
are my
आपके
virtual
फैन
friends.
आप सबके फैन हैं हम लोग आपके फैन हैं मैम
नहीं,
वी
और
फॉलो
मैं आप लोगों की fan हूँ.
थैंक
No,
यू
you're welcome, Sabine. Welcome. No, I just love the fact that you all are working together and you're all trying to help each other, and I think it's good for everyone. It's really, I think it helps everyone. It makes me read. It really makes me read. So one more thing I'll end up with. So,
Yeah.
one of our ICU doctors, he's brilliant. I mean, he is so brilliant. It's incredible. And so he stayed in the ICU for a month. He didn't go home for a month because here the doctors who are working with patients, like ICU patients, they're not going home. They're taking some Airbnb or staying in a hotel or whatever. So he just slept in the ICU for a month. That's where he lived. And so I was talking to him, and I don't know, but I'm just bringing it up because somebody may think about it. If somebody a mild case, how do we know that person is not going to get moderate to severe if it's within the first few days? Should that person be on prophylactic, like Lovenox or something, or heparin or something? We don't know. So I asked him, I said, why can't you just give that? But he said there's no data, and I actually looked it up, and there is a slight possibility that might be more harmful than helpful. But we will know more about it, because I really hope nobody clots, because clotting is what's causing a problem. And I know people want to take, I probably will want to take Lovenox if I get the infection and I'm mild, but we don't know necessarily that it'll help. It may worsen the things. All right. Well, thank you. Thank you so much. And, thank you to InnovaCare, is it?
Yes,
Yeah,
ma'am.
it's
Yeah.
great that they're helping you bring this series out. I think that's really wonderful that they're helping educate all the physicians and interaction. So thank you.
Thank you, ma'am. Yeah, over to you, Sankalp.
Thank you so much, madam. Thank you so much, Dr. Ritu. Thank you so much, Dr. Asha. It was so nice of you that you have come again and helped us to spread the knowledge across the country, ma'am. Thank you so much.
Right.
Okay.
Thank you very much.
Yeah.
I think it was a very, very exciting session. I think it was so informative. I think it's been really enlightened us to the extent, I think all my audiences and everyone who was listening to it, I believe this would really have thrown light on it, and absolutely to the point, and such an explicit explanation. Thank you so much, ma'am. We are so very delighted to have you today. And
Thank
thank
you.
you, Ritu, ma'am.
All right.
Thank you.
Yeah. Thank you. Thank you. Before we wind up, friends, from the September month, we are starting a series in which we are celebrating whole month for the teachers. For the Teachers' Day as on the 5th September, but on the whole month, I am inviting the teachers. So on the 5th, we are having Dr. Rishikesh Pai sir with us. 6th, we are having Dr. Nandita ma'am. Again on 12th, we are having Rishma Pai ma'am. Then we are having Hema Divakar ma'am, Sunita Tandulwarkar ma'am. all the stalwarts are coming on the September month, so please stay tuned with us. As today on the 25th episode, I have invited the legend, the Asha ma'am. Hope to see you soon, ma'am, again with another episode. Thank you so much,
Thank
ma'am.
you.
Yeah.
Thank
Okay,
you.
bye. Yeah.
Good night to all of
Yeah,
you.
good
And
night,
thanks
good night.
to everyone for attending.
Yeah,
They
yeah.
have stayed late at night on a Sunday. I really thank all of them. Das, Vadva, everybody. Yeah. Thank you. Good night.
Yeah.
Thank you.
Good night, ma'am.
Pleasure is ours, ma'am. Thank you.
Bye.
Good night.